So I don't know if you all are Harry Potter fans, but I'm a Harry Potter fan. So what we really need, of course, is a sorting hat, right? Do you remember the sorting hat? So the kids go to school.
Slytherin or...
Yeah, which house are you in?
Yeah.
And if you're a stage 2 colon cancer patient, you're in one of 3 or 4 houses. You're cured, which is sort of the Gryffindor house, I guess, or you're not cured, but 5FU will fix you,
Hufflepuff.
which is Hufflepuff, yes, I would think, but then of course the other one is you're not cured and it won't cure, and 5FU won't cure you, and so that's the Slytherin house,
yeah.
of course. So what we really need is that kind of thing for our patients, and so what we're getting right now are these gene profiling tests. There's the Oncotype test, there's the Coloprint tests that aren't quite the sorting hat. They sharpen grayscale, as the way I think of it, and give us reports back that say if you give chemotherapy, here's your chance of having cancer, and if you don't, here's your chance, so based on retrospective analysis. Alan, start with you. What's your use of these things? Do you think they're valuable in certain patients? When do you order them, if ever?
So having published a paper and done some research on this, I can tell you that I use it infrequently, although occasionally. I use it to break a tie, and I use it often when patients are ambivalent about what to do. They're all they're all different gradations of stage 2. A patient with 30 negative nodes and a 6 centimeter primary with 30 negative nodes, I think that was likely a cancer that had very little likelihood of spreading because it's been there a while, it's big, and it's 30 negative nodes. So as you look at those other nuance factors, to me it's the patient who's on the cusp, who might have 15 negative nodes or 14 negative nodes. There are other features that we talk about as reflecting high risk, lymphovascular invasion, for example. Now, the Oncotype DX score has been shown to be independently helpful beyond that. I think the problem with the scores, Oncotype, for example, is that there's not a wide range, and most patients fall right in the middle of the curve. So does a 12 versus 14% risk of relapse really make enough to treat you? Some people it might, others not. And recall that these scores do not tell you you will benefit from adjuvant therapy. They tell you your likelihood of relapse. In fact, we've done some work and are doing some work using the score to model it as a surveillance tool, following the diagnosis, following treatment. What's your risk of relapse, and could that give us some guidance of who to look for and who not?
How often? Yeah.
But again, to me, it's when the patient really wants chemotherapy, for example, and we might get the score to see if we can dissuade them. But I do not find it as a big difference maker. And there are other tests, of course. Yeah. You can look at lymph nodes. There are a whole host of other tests. To me, none of them really give us the guidance we need.
So no magic sorting hat?
I don't think
yet.
so.
Excellent.
It's interesting, though. We ran a study using the utility of these tests in a community-based setting. We are experts. I think we know what the average recurrence risk of a stage 2 patient is. And it's interesting for me to see that in stage 2, Oncotype DX, for instance, was able to change the treatment, the pre-planned treatment, in 40% of patients. And a lot of patients
usually
actually
toward not being treated.
To treat patients, not to. And I think it's mainly because it's an educational tool. You actually it tells you kind of a number what the percentage of risk recurrence is, and all of a sudden adjuvant therapy doesn't look that great and promising anymore because we are routinely overestimating what we can do with adjuvant therapy, especially with oxaliplatin, 5FU, or fluoropyrimidine-based therapy, where 2/3 of the benefit is carried by fluoropyrimidines anyway.
Right. So, Dan.
Just to bring back the whole issue of trying to distinguish between the familial type of MSI versus the more sporadic type. Because in one instance, in the familial type, you can raise a whole series of new questions related to what other members of the family should be doing. You don't want to do that unnecessarily, but also in an individual patient, how often do you screen them for endometrial cancer? How often do you use routine colonoscopy? It's not every 10 years because those people develop colon cancers more frequently. And in fact, how often do you do a near total colectomy for their first episode of colon cancer? So I think distinguishing those two groups of people is incredibly important, and that's why I'm very glad we have a genetic counseling clinic and a family counseling clinic to help me in those decisions.
One last thing on adjuvant therapy and then moving on, and this is Axel was bringing up a little bit, this role of oxaliplatin in stage 2, quote unquote, high risk. And when at this meeting, we're actually going to really stare at the comparison between NCCN guidelines, ESMO guidelines, and the NICE guidelines and we're going to compare and contrast how similar groups, smart people, take the same information and produce different recommendations, right? And so the NCCN guidelines for quote-unquote high risk, which is node count, it's lymphovascular invasion, and the like, it gives 4 options, but the top one is oxaliplatin-based therapy, right? So based on what? And so I've actually stopped using oxaliplatin in stage 2 patients based on the Mosaic data. So help me understand, you NCCN people, why is that on the top of the, they're all choices and they're equally weighted, don't get me wrong, but it's the top one on the list, if you will. Where's that data? Should I be actually giving oxaliplatin to that patient with 11 nodes or lymphovascular invasion?
So you're impugning my reputation. I'm the vice chair of that
There you
panel.
go.
And Axel is newly appointed, so he can't take blame for this.
I got you here. You're on camera. So what am I
Recall
going to
that
do?
there is no intended order or hierarchy in the listing of the choices. So
But
the
why
fact,
is it there at all?
Well, so it's there at all because if you look, it's a complicated question, but if you look at, first of all, if you look at Mosaic, our fundamental trial for stage 2 versus stage 3, a stunning majority of patients with stage 2 disease in Mosaic actually had high-risk stage 2 disease because of inadequate nodal sampling. 40%, I believe, is a number that sticks in my head. I think the problem generically is isolating one factor versus another for what really constitutes high-risk disease. The whole concept of perforation or locally extensive disease, which are classically called high-risk features, is based on studies in the 1970s and 80s with a handful of patients. Literally, this is hardly a big data set. So the basis for NCCN's guidelines has been a relatively, an effort to be a strict interpretation of where oxaliplatin has been shown to be of benefit. And in Mosaic, it was not shown to be a benefit in stage 2. Again, the high-risk stage 2 and what constitutes a high-risk stage 2 is a different question. And flip it around to stage 3 patients, many of whom we clearly overtreat with oxaliplatin. And if you look at the Oncotype DX from the NSABP study, we see a substantial overlap and where patients have similar risks with stage 3 or stage 2 disease, but on their score have similar risks. So the guidelines are there to be inclusive, frankly, the NCCN, and that's why it's included as an option. Do I practically use FOLFOX in stage 2 patients? I do not.
But let me chime in here because even as a newly appointed member to NCCN, I can actually see where oxaliplatin comes from. So the endpoint, the primary endpoint of Mosaic was disease-free survival. And there is, in high-risk stage 2, there is a benefit in disease-free survival with oxaliplatin-based therapy. Now, it's disease-free survival by
It's about
itself.
that much, but it's a number.
There. It's a number. It's statistically significant or whatever you want. So we know that patients, for instance, with T4B N0 tumors do worse than patients with stage 3A tumors.
Correct.
So I think, our arbitrary, stage 3, everyone gets oxaliplatin. Stage 2, we shouldn't consider oxaliplatin. It's probably wrong. There's more to prognosis than just stage. So leaving it as an option for discussion, I think is very wise by NCCN because, patients want to be involved in these discussions too.
I think the challenge to me, as Axel alluded to before, is those of us who live and breathe this disease are relatively facile in describing the data and where the data holes are. I think in the community, it's much tougher for them to navigate this. It's got to be incredibly complex.
But this is where I'm sensitive to it. So if I'm treating somebody and I don't deal with it all day, I'm going to pull out the guidelines. And if it's the top one on the list, I'm going to think that's the one.
Yeah,
so there's a visual, even though the fine print says we don't know.
Right.
There's a visual that says that. So I just encourage us to make that product that we're sharing with our folks to help in their practice.
Actually, a good thought. The thought of actually putting on each page that the order that things appear is not necessarily, the intended
because
the
what lists is it lists oxaliplatin, 5-FU, no treatment,
Correct.
or clinical trial. Those are the 4 choices in
it's a
this
good point.
patient.
But I think it reflects reality, and I think it's permissive so that physicians are not boxed into, because as you pointed out, if someone had a stage 3A with one of 37 nodes, they probably should get 5-FU capecitabine alone.
Exactly.
Whereas if you have a T4B tumor with a high recurrence score, you should be permitted to use oxaliplatin.
So it's defense against the Aetna dark side, right?
Yeah,
That's a little part of it, yes.
that's why that's why it's so difficult to really capture all the potential cases, in a guideline.
Yeah.
And I think that's real life.
Sure.
Yeah, so this is where I think there's personalized medicine has a little bit of a molecular feature. There's this MSI test, there's the tie-breaking sort of molecular testing. But at the end of the day, I think this is a lot about, so I use the benchmark of about a 15% risk recurrence for the average stage 2 and a 1/3 reduction, 5 absolute percent by chemotherapy, of which, to Axel's point, 2/3 of that comes from 5-FU. And if you want, this is why it's all, and also disease-free survival has its own value proposition to some patients, but the usual extrapolation is that survival benefit is actually a fraction of disease-free survival. So this is all about what does a few percent mean to you, whether you want to upgrade to the exercise of oxaliplatin, or keep it light in the middle with capecitabine, or say, thank you very much, all this drama is not really worth it to me. And I think then you have to incorporate the patient's personal issues, comorbidities, and a lot of other things. And I think while there are a lot of issues, including do you have a slightly higher risk or lower risk based on extensive lymph node profile, I think people can work through this. And while it would be nice to sort of have a more, algorithms which are sort of point us, until there's an app for that, I think if you stick
for that, I'm sure.
yeah, that we just need to sort of use common sense, and I think discussing with the patient what the few percent mean is probably, at least for me, is the biggest organizing principle.
We got to move on to metastatic.